So here's all the details of the shoulder range of motion. So you can go either with goniometers or inclinometers. Okay, so the same kind of thing that we talked about before with the goniometer, you're going to have the fulcrum, you're going to have a fixed arm and a mobile arm. Okay? So for shoulder flexion, okay, so then the fulcrum is going to be at the lateral aspect of the chromium process here. Okay? And then the fixed arm is, you're going to use the rib cage as a reference. So it's parallel to the mid-axillary line of the rib cage. And then as the shoulder moves forward, you follow the long axis of the humerus. So you're going to aim towards the lateral epicondyle. You can measure like that. And then extension, you're going to come back this way. Okay? If you're using an inclinometer, at this point you don't really need two, you use one, and then the fancier ones will have a nice arm on it like this, or you can do it the cheap method like that. Just put it on here. Basically, you're just putting this along the long axis of the humerus, and then you're moving up like this. Okay? And then the thing is that if you to really do it reproducibly and AMA kind of guidelines, what you do is you have the person sitting in a chair, and then one arm is holding on something like this so that you're going to stabilize the rib cage. Because obviously if I do this, I'm going to be able to flex more and extend more if my thoracic cage is moving. So instead of using dual inclinometers and subtracting one out, what you're doing is you're putting the person in a chair so they're sitting in a chair like this, and they're holding on like that. So now my rib cage is frozen, I'm going to be doing this like that. Okay. So then you have abduction, adduction. So they're standing or seated. So if you're using inclinometer, you'll have to kind of bend the body forward like that because you want this to stay in that plane like that. You're measuring this way and up like that. And then if you're using a goniometer, so you're using the anterior aspect of the chromium, and then the same kind of thing. Fixed arm is midline of the anterior aspect. So it's, you're using this as a reference, and you're just lining it up, and you're keeping this parallel to that. So you're sighting it here, and you're keeping this parallel with that. And then they're bringing their arm up like that. And then again, to come here, you have to come forward of the body here, and you measure it across like that. Okay? Internal, external rotation. Can I measure it like this? What am I doing here? Yeah, it is moving the shoulder, but you're also doing pronation and supination. Okay? So you need to lock the elbow like that. Typically you're going to do that while they're supine. And you're going to measure from here is going to be external rotation, here's going to be internal rotation. Okay. That's one thing that people get mixed up, and they say, okay, how am I going to do internal external rotation? So just think of it, you're going to be like this or laying on the table like that. They have to be kind of over to the edge of it, like from here. You have to have room for that to move. If I go like that, the table stops it. Okay, so I'm going here, going there. So if you're using the inclinometer, they're laying on their back like that, and this is going to be either horizontal or vertical, and then you just measure that back like that, external, internal. Okay. All right, so there's a lot of shoulder tests, in case you haven't noticed, right? So we're going to divide them into, again, like always, inert tissue tests. And so what kind of tests are, what kind of injuries are those going to be tested for? What's that? Yeah, or specifically for the shoulder, what kind of conditions? Dislocations, okay? Separations, things like that. Then when we get into contractile things, what are we going to be doing there? Muscles, tendons, we're talking about tendinitis, rotator cuff tears, things like that. Then you get into some that are kind of mixed tissue tests, where we talk about labrum tears. Okay? It involves inert tissue, but yet the way that you're testing it, you're using a contractile tissue where you're doing testing some type of resistance. So that's kind of a mixed tissue type of thing. Okay. So there's the details of the rotation. That's all just right out of the mouth. Again, upper extremity, if there's pain getting to the shoulder and it may go down into the arm, it's still appropriate. You may be doing dermatomes, myotomes, reflexes. Okay? So basic things from the 5-minute neuro. And then palpation. All those different things that we mentioned. Okay, you're going to palpate here, sternoclavicular, acromioclavicular, acromion, different tendons, all the different areas there. Rotator cuff, palpate along the spine of the scapula, different angles of the scapula, humerus, the coracoid process. And then when you're doing that, you're looking for the texture of the tissue, palpating for changes in temperature, all those kinds of things. All right, so now we'll get into the shoulder tests, and I think we probably have time. We'll go through some of these and we'll get out the tables and practice these because we really need to be on the tables for these. Okay, shoulder apprehension test. How does the shoulder most commonly get dislocated? Not like this, anterior, inferior. So this is one of those types of special tests that we're reproducing the mechanism of injury. So we're starting to slowly put the arm into that position. The patient knows that that's usually the position that their shoulder's in when it dislocates. So they're not going to want to have that go into that position. The neurologic system has been wired so that they don't like that. Consciously, subconsciously, whatever. You're going to start to have pain, or they're going to try to avoid that. Okay? If you go into, and then that's going to indicate that it's an anterior inferior instability in the shoulder. So while they're in that position, if they're starting to have apprehension about that, starting to get into here like that, and then now we push that back down, and that reduces that apprehension, that's another confirmatory thing that's showing that, yeah, there is a problem, that when I put it back, then that tends to relieve the problem. All right, now the other type of shoulder dislocation, how does that happen? Boosh. Okay? And now this is where it gets into the thing with the whole understanding the plane of the scapula and the plane of the glenohumeral joint. So we're going to move this shoulder. If I'm pushing like that, is there somewhere for it to go? It's jamming it into the joint, right? If I put it this way, that's like what we say the back door of the shoulder joint. So if I'm doing it here, it's jamming it into the bone. So I need to do about 30 degrees of abduction and then push back that way. That way there's an opening for it to go. So I'm going to come and go like this. I'm not going to push straight back like that. I'm going to put the arm here. I'm going to be pressing here, and I'm pulling back this way. Okay? You can do that seated, or the patient can be supine. In that case, the table that they're laying on is acting as a support for the scapula. And then, again, I'm not pushing straight like this way, I'm going like that, I'm pushing this way. And it's also in a superior direction as well. I'm not just going straight like that, going back up like that. Okay.